You see, robots are placing implants now. The question really is, should you trust them or not? Would you let a robot place an implant in your own mouth?
Not today. Somewhere in the vicinity of 200,000 US dollars. It's for this robot. And it occupied the good part of a room. But sometimes 1 millimeter is 1 millimeter to the nerve. You want it to be your assistant, not you, its assistant. I don't want to be the dinosaur in the room. Probably very controversial, but I would probably ban zirconia implants. People don't want to sit here and listen to two robots talking.
So, robots are placing implants now, right? Should you trust them at this point of time or not? The robot's placing dental implants right now, not in lab, not in a trial, in real patients, in real clinics, and mostly in America. And the technology is coming everywhere else. And it has actually split dent implant surgeons into two different aspects. One side says this is the future and it provides accuracy beyond any human hand. On the other hand, the other side says we are training a generation of dentists who will not be able to operate when the technology cannot. You see, my guest today is one of the very few people who can actually judge that argument rather than just react to it. He's an implant and reconstructive dentist in Sydney. He did his master's in oral implantology at Goethe University in Frankfurt. He uses guided surgery every week and he studied robotic assistance as part of his training. So today we're asking the questions properly. You see, robots are placing implants now. The question really is, should you trust them or not? Dr. Jono, welcome to Between Patients.
Thank you. Thank you for having me.
Absolutely, Jonathan. Pleasure is all mine to have you on the podcast. So let's start at the beginning. Why dentistry in the very first place?
Dentistry for me was a really good combination of art and science. So growing up, I was part of a medical family. Parents were quite heavily involved in the medical field, so I always thought I wanted to be a medical practitioner. Then over time, as I continued throughout my high school education, I realized I was really interested in art and sculpture and hands-on skills more so than science and science alone. So started to pivot towards dentistry and feel that that was possibly a better fit than what the medical world was going to give me. Ended up in dentistry, probably like so many people, not actually really truly knowing what's involved and slowly learning that through university. And thankfully, it was something I actually fell in love with and something I do really enjoy doing. Rather than it being a waste of 5 years, it turned out to be something quite enjoyable in the end. So I was very happy with my choice.
Definitely, it's the scenes, and you talked about the medical field you want to go into, and so why implants specifically? I mean, there's other professions in the dentistry itself, and in different categories. Why implants?
So the first few years after graduating, I definitely kept my options fairly open. I tried to do as many different types of dentistry as possible. I delved into a little bit of orthodontics, root canal, endodontics, uh, prosthetics, a mixture of everything really. Tried to keep my scope as wide as possible, but slowly realized that surgery was something I was really interested in, and implants seemed to be the future where it was all heading towards. It seemed to be the best way that I could replace missing teeth, and quite a lot of patients had missing teeth. So naturally, I wanted a technique and a skill that I could employ on those patients to be able to give them something better than what we currently had. And prior to that point, all we did were dentures or bridges, and that didn't always work for a lot of people. So implants for me was the next logical step.
Got it. That makes sense. And I do see, you went to Germany for your master's at Goethe in Frankfurt. So the question really is, why exactly, you left Australia and such a beautiful country, and you went to Germany to study implants? Why specifically that decision?
Yeah, it's a good question. Germany was thankfully not full time. Well, that's sort of a lie. It's full time, but not in person full time. So it was mostly remote study and remote presentation of thesis, and the hospitation period was also remote under supervision with local dentists here who had also done their masters. And we would spend a couple of weeks every year over the 2-year period, going to Germany and doing more study there and lectures in person, as well as some practical components in person whilst overseas. So over the 2 years, we spent probably a total of 8 to 10 weeks overseas, and training at the university and local institutions. So Germany came about because it had quite a good reputation compared to the Australian master's programs, but it did have a bit more flexibility as well. A lot of the master's programs in Australia meant that you wouldn't necessarily be able to work part-time and study the program, and so I couldn't at the time afford to stop working. So the Germany one seemed like the logical option, so that I could still continue my work and also benefit from a degree at the end of it.
Got it. That makes sense. So definitely, it was hybrid. It was remote. And is there anything specific that
Yes.
Goethe taught you that a weekend course just never could?
Yeah, absolutely. Yeah, absolutely. There's a huge benefit in studying a didactic degree over a fairly long period of time that covered everything from fairly basic things, which up to that point we had already placed quite a few implants. They don't usually have an intake of dentists who have never placed implants. There seems to be a bare minimum that most of the students there had placed, some less than others and some significantly more than others. But it's still a program that tailored from a beginning point to a more advanced and end point. It started off with the basics, the surgical principles, and really recapping the things that one should already know. Because there's students from all over the world there, it's hard to know what they do and don't know. And I believe the German education system really wanted everyone to be starting at the same point before they continued on to more complicated topics. And over time, we started to study more advanced bone grafting techniques. And then, of course, it became a little bit more about full arch restorations. And we had guest lecturers from all over the world who, in their clinical practice, were leaders in their various countries. And it was a real privilege to learn from some of the best in the world, not just the local dentists in Germany, and the professors, but also some of the best overseas dentists as well.
Hmm.
And of course, topics like guided surgery and robotic surgery and more complicated topics definitely came about. And we were pretty lucky to have some lectures from some of these professors and dentists that themselves had done quite a lot of these procedures. And we got to learn firsthand from them what it was all about.
Got it. That makes sense. That's interesting. So definitely, I do now understand about what was it like at Goethe and studying over there, and of course, how exactly you eventually ended up proceeding and pursuing the implant specific category itself rather than going into endodontics and all the other stuff. Now, I definitely want to set the table for everyone who's watching and listening. When we say guided implant surgery, what do we actually mean? Like, explain it to me as if I was one of the patient.
Yeah, absolutely. So guided implant surgery is a very broad umbrella. I believe there's some classifications in the medical field altogether that have different levels of autonomy and levels of what it means to be guided. From, of course, not guided at all to being partially guided to being partially uh, assisted, autonomous and robotic, but assisted to fully robotic and but are still under supervision, and then of course probably robotics that are not at all really controlled by humans. So that's probably within the medical world more so than the dental world. I'm not as familiar with how far it has gotten in the dental world. Definitely in the local office, robotics are far and few in between. The robots themselves are extremely expensive. I believe at the time when I did the masters, there was a gentleman from New York who had a robot in his clinical practice, and I remember him telling us it was somewhere in the vicinity of 200,000 US dollars. It's for this robot, and it occupied the good part of a room. To be able to to walk around it would have been difficult if you didn't have a very big office. So that's the extreme side of it. But then, of course, guided surgery can be as simple as a static guide, a piece of plastic really that's 3D printed with a hole in it, and you're guided surgical kit, which is a set of drills that are designed to follow the path that's already pre-printed in this plastic sleeve, and that's of course guided previously from a dentist doing the planning on his computer software to indicate to the technician where to place the implant digitally. So then the guide, when it's printed, is preempted or premeditated plan, and one, as they say, simply has to follow the guide. But that's the most basic version to the most extreme version, and then there's the halfway point in between, and that's the dynamic navigation. So dynamic navigation is where the plan is already pre-done as well, just much the same like static guides. But then the implant motor is connected to a device, a robotic arm of sorts, that only allows you to drill following your plan. My apologies. That is more the robotic, but the dynamic is where it follows your plan, but you can see live on the screen where your drill is going, and whether it's following your osteotomy plan, your drilling plan, or whether it's deviating from your drilling plan or not. And you can effectively change it on the spot, hence the name dynamic. If you feel like you're not drilling in the right way, you can change your position, but it's giving you a live feed as to what you're doing versus what your plan should be, so that you can dynamically adjust what you're doing. So that's the sort of the halfway point. The robotic being more hand holding in a sense, the dynamic being more controlled by you, but still monitoring everything that you do, and then the static is really reliant on what your pre-plan was, and you have to hope that it's following it as it's intended.
Hmm. Got it. That makes sense. So there's definitely classification in it, and you use static guides routinely. So walk me through what a guide changes in your hand on the day of surgery.
Yeah, absolutely. So, in my opinion, I believe that a guide can, at first, add an additional layer of complexity. Because if your surgical plan is hopefully creating this guide, or this guide is based on your surgical plan, your guide needs to fit. And occasionally, the guide doesn't fit. So, sometimes it adds a layer of complexity at the start. But what it does mean is that once it is ensured that you ensure that it does fit, it can simplify your workflow. So it adds that layer of predictability to your positions if you're running in an area between two teeth, which is quite narrow, and you're not sure whether you're 1 millimeter to the left or 1 millimeter to the right, then the guide can assist you in getting your position of your implant as you have planned it to be, and not getting deviated by anatomical factors that otherwise might put you off if you're going completely freehand. There's lots and lots of studies out there, and they keep getting updated, various randomized controlled trials, meta-analysis, that show rough numbers. I say rough numbers because obviously it's a huge portion of data that they've collected, and there's lots of variables that have to be taken into consideration, which a lot of these studies do take into consideration, but it is hard to say that the numbers that they produced are uh, biblical numbers, so to speak. You can't sort of rely on them being the be all and end all. So I wrote down a couple of numbers before, and for example, they said that the entry point they found over all these studies was maybe only 1 millimeter or 1.2 millimeters of deviation from where your plan was, or the tip of the implant was only 1.4 millimeters of deviation on average, the mean deviation across thousands of cases that had been analyzed. So it doesn't sound like much when taken into the grand scheme of things, but sometimes 1 millimeter is 1 millimeter to the nerve, and then you end up with a problem where you've damaged the nerve, or an adjacent tooth could potentially be involved. So 1 millimeter isn't a lot, and it is probably a higher number than freehand, but freehand is difficult because there's lots of operator error that needs to be taken into consideration there, and every surgeon is going to be quite different. So I would say that it adds a layer of complexity first, but once you're comfortable with it and know how to troubleshoot what a guide can help you with, then it does add a layer of predictability and efficiency. So that for me is where static guides are most helpful in controlling an outcome. And finally, and probably I would say even more importantly, is that you can figure out your prosthetic outcome before your surgery when you're getting the lab to make you a guide. So at the end of the day, implant surgery is all about the tooth. It is a prosthetically driven discipline rather than a surgically driven discipline. So if I can reverse engineer the position of a single tooth or a bridge, which is the end outcome, and then ideally place an implant to suit that, then a guide can really help me follow that plan and not be thrown off by the local conditions that I see in the person's mouth at the time. Because I can trust in the fact that I've done the planning to know that this is the best place for where the tooth ultimately needs to go. And then I can modify what I do in the mouth to make sure the implant ends up there so that the tooth down the track ends up where it should be. So prosthetically speaking, it can really elevate the predictability of where my teeth are going to end up.
Okay, got it. So just to kind of clarify over here, is freehand is definitely difficult to do, and it's the same case with the static guide. It adds up complexity in the treatment itself. But there's one definite thing that if we're using static guide, it's just simply going to add predictability and efficiency in the treatment itself. Correct?
Yes, that's correct. Yeah, it will just improve the efficiency in the treatment and a degree of predictability as well in the treatment.
Got it. So the degree of predictability, that's fine. Now, I definitely want to talk about, is there any sort of a specific case where you would never do that as guided? And any sort of like a case where you would do that as freehand, like any sort of comparison or difference that you typically have before any sort of treatment that you typically analyze before treatment?
Yeah, there are definitely cases where I do. I'd say probably more than 50% of my work is unguided, is freehand. I'd say there's a good chunk of my
All right.
clinical practice which are single implants or multiple implants with adjacent teeth still present. And then a really big portion of my clinical practice is full arch reconstructive work. So at that point, there are no teeth left in the mouth, and we're rebuilding with your typical all on four, all on six, or all on X, however some would like to call it. So the positioning of the implants allows for a greater degree of flexibility than one would assume for individual implants. The teeth themselves are not necessarily going to be directly under the position of an implant, and often these cases don't present with the most ideal bone for the implant to be placed where the tooth root used to be. So we're often doing a lot of angle corrections and adjustments of the position of the implant in relation to where the teeth are going to be. So often following a guide can work, but it does add a much higher level of complexity, and it adds a layer of cumulative error as well, because sometimes the guide either then becomes bone supported, so the initial placement of that guide, if it's not 100%, then all of your implants are going to be off. So you're really reliant on the very first positioning pins to go exactly where you want them to be for everything else to work. Then some will say, well, you can do a combination of tooth supported to put some implants in and then remove the remaining teeth and rely on those few implants to be ideal for the next guide to then work and place the remaining implants that you might have left to place. So then again, it's a bit of a cumulative error. If your first few implants are not ideal, then the second lot of implants are probably also going to be skewed. So I find with full arch, there's definitely lots of incredible clinicians out there that have really, really accurate outcomes with their implants. But for the style of full arch implantology that I do, I find that being freehand gives me that degree of freedom that I can benefit from to be able to get the high level of primary stability I'm seeking when I'm intending on placing them into a set of teeth the day after their procedure. So it's a bit different than in a single or multiple case where you can close the gum off if the stability is not there. There isn't really too much importance on primary stability because after a few months everything will be fine. But with full arch, we really need those implants to be stable. And if we follow the guide and the implant's not stable, we're running into a bit of a problem. Of course,
Yeah.
it's in the right place, maybe, but if it's not stable, it's no good to anyone. So that's where I don't like the idea of guides for full art surgery.
Yeah, 100%. I would absolutely agree on that because the other day I was recording and speaking to Dr. Baska. I recorded a podcast with her, and we actually talked about this specific topic, not specifically about guides, but definitely about the biology of patients. You know, patients being not being pleased after the treatment, and I believe it's really important for all the dentists out there to really understand and analyze the difference between using a static guide. What are the pros and cons of it?
Yes.
And what are the pros and cons of being freehand and doing the surgery through that. And if you just simply analyze that core psychology, what it actually goes behind that, it's just going to help not only the treatment, but it's just going to help the patients a lot. Because at the end of the day, they're not going to be complaining about in let's say the full art, right? The
Yes.
the the tooth, they weren't in the right spot. So I believe it's just going
Yeah.
to help them a lot, isn't it?
Yes. Yeah, that's exactly right. And it is like you said, the biology is very wildly different from person to person. And whilst you can rely on a guide to get you the implant in the right place, you can't predict the bone quality and quantity as well as you'd like to all of the time. Sometimes it seems really stable on an x-ray and it seems like the bone is going to be very dense, but occasionally these metrics are a bit off and the bone might end up being a lot softer. You can quite often tell if bone is going to be soft in advance, but there are some cases over the years that I've bumped into where I thought I was going to get miles of stability and tons of stability, but really the bone was a lot softer than it appeared. And so I've had to deviate from my plan on my computer, even though it's purely brain guided, as we say. I'm hoping to put an implant in a certain location, but if it's not good, I can easily move left or right. And so that was a circumstance where not relying on the guide as the be all and end all meant that I had that freedom to adjust mid surgery and not worry that I was going to create an adverse outcome for the patient. So biology is a huge factor, and each patient absolutely will be very different.
Definitely. So I definitely want to ask you a question like how much does the guide workflow actually add in time and in cost?
For a single or like a single unit implant that's fairly straightforward, it's from a cost perspective, it's not very high. Depending on which lab you might send it to, it might be a few $100s. The planning is done all in advance. That might take 15 to 20 minutes by the time you import the implant into the edentulous site and position it where you would like it to be, and then sending it off to the lab. And usually, a lot of these labs are pretty good at making minor adjustments based on where they think the tooth ideally should be. And then they print you the guide, which can be made very, very quickly. And some people can even print it themselves in house, and that would further reduce the cost as well. So let's just say it costs a few $100s. Then the day of surgery, it often for me with a simple case, it can save quite a lot of time. I don't necessarily need to measure too many times what I'm doing. I do have to then rely on the guide. So the surgical placement can be very rapid at that point. If I'm confident in how things are feeling as I'm drilling, I'll trust in the system and place the implant through the guide. Sometimes in 5 minutes or less. So it can be very quick if everything is going very well. And so it can definitely save on time for fairly simple cases. That's of course having
Mhm.
said that, having placed lots and lots of implants, thousands of implants over the years, I can kind of tell what I'm doing even though I'm drilling through a guide. So for someone that's probably a little bit less experienced, it still will save them time, but it can detract a little bit away from knowing what exactly it is that they're doing or knowing exactly the quality of the bone they're drilling into and how they should modify what they're drilling into as a result of the quality and hardness of the bone. So it can make it more difficult to get a good feel of what you're doing if you are just relying on the guide without having a prior history of a lot of experience. So that's where it can sometimes fall short. And when people ask me, can should I do this case as a guided case or not, if they're still learning, I like to tell people, of course, surgical principles should 100% be the first thing they learn, and then I would really encourage them to do freehand placement first. Of course, there is that degree of risk if they're not confident in their position and they're worried they're going to hit something or place the implant in the wrong place, that there is that risk when first starting out. So often the thought is, well, let's get a guide so that I can reduce that risk. But unfortunately, you really flatten out your learning curve in learning how it is to place an implant, what the bone feels like. So whilst you're possibly improving surgical predictability, you can run the risk of really reducing what you're learning. And in the long run, that can affect your progression in what you know and how you fix things when they go wrong. So best then to say, well, maybe have someone with you that is more experienced and go ahead and do it free-handed with someone maybe looking over your shoulder or checking along the way to make sure you're doing a good job. And then maybe after 20, 30 implants, 50 implants even, then you can start to introduce your static guides,
Yeah.
because then you've already got a bit of a feel for what it is. And it can help you take it to that next level of predictability, because you kind of already know where you're going with it. And then, of course, if we were to get into more complicated stuff, then I'd say if you've placed several hundred implants, then maybe you could look into doing dynamic and then robotics and things like that. But you really have to know what you're doing before you start to rely on technology.
Yeah, absolutely. I believe, just like you've mentioned, experience is something that there isn't any sort of other replacement for it. I mean, look at you, you've placed thousands of implants. And if somebody's starting out, having only placed about 10 or 20 implants, I believe they need to set thresholds for themselves, right?
Yes.
For instance, at 50 or 70 implants done, then they should be the one implementing static guide. And upon hitting 500,000, that's the point they should be pivoting towards dynamic and robotics, right?
Yeah, exactly. It's the more complicated the system, the more complicated the possible problems that could happen. And if you're really heavily relying on that piece of technology to deliver the outcome that the patient needs, and you don't have the experience to back it when something goes wrong, then you're going to really be like a frog in hot water. You'll be really stuck, not knowing how to recover from a
Yeah.
situation because you've relied on that piece of gear to get you the outcome rather than relying on yourself and the piece of gear just assisting you to get there. You want it to be your assistant, not you, its assistant.
There you go. I believe that was very elaborated when we talk about the static guide and, of course, the difference of it. Now let's actually get into the robotics, right? Because this is actually the big one. I've done some research about it. So robots are placing implants in America right now. Right?
Yes,
Yomi was cleared by the FDA back in
that's
2017.
correct.
So this has been in real patients for nearly a decade. Right. So you have also studied the robotic assistance in your training. So what did you actually learn about it?
So there was a dentist that had done his master's many years before I had, and he got invited to Germany to give us a lecture on robotics. He had one at his office, as I mentioned before. I think maybe he even had two. I don't know whether he had two at the same time or if he had tried two different models over the years. So this was not so long after it had been approved. So I think he was one of the first in New York to have the robotic system. I can't recall his name off the top of my head, but he was a lovely guy. And he had been placing implants for a number of years before that. But he wanted to have that little bit of extra edge over, maybe you could say, over his competitors. He wanted to have a piece of equipment or piece of technology that he could deliver treatment to his patients that very few people could say that they offered. And he definitely found a place for it in his practice. It might not have been. I don't believe off the top of my head it was a full arch practice. It was probably a single implant style of practice, probably mixed with cosmetic work or prosthetic work. But he believed in the technology, and I know that lots of other people who have researched this probably believe that it has a place in the future as any other technology is. It's still a work in progress. 10 years later, yes, absolutely, but the accessibility level is not quite there yet for a lot of implant dentists who place a large volume of implants. So whilst it has been around for a long time now, I don't believe that enough implants may have been placed with it just yet. And I can't unfortunately give you quotes or studies to see how many implants truly have been placed. That's something I'll probably have to do a bit of homework on. but I know there's a few systems. Yomi is one
Hmm.
of them, like you said. I believe there's one called, yeah, I wrote it down because I knew I was forget it. Yokobot and the Remibot. I believe there's three. I'm not sure if those other two are FDA approved just yet, but I'm sure that will come with time. And they they are very interesting because they are not fully automated. So the idea behind them, as far as I understand, is that they hold the handpiece, the implant motor is directly connected to it, or you can connect it to a robotic arm. And you have your pre-planning as you otherwise would, because the robot doesn't do the planning for you. You still have to do the planning yourself. And you hold onto the handpiece yourself as if you were going to do the implant freehand. And it has a variety of cameras and sensors that are placed strategically around the room that can see where the robot arm is. And it, as you're moving the hand towards, moving the handpiece towards the patient, it's tracking your movements. And so it doesn't allow you to push the handpiece in a direction that it believes is incorrect based on your planning that you've done before the surgery. You can forcefully adjust the handpiece and it will sort of let go of its control over the situation. But if you're fairly delicate in the pressure that you apply, it will guide you exactly how your plan is laid out to be. Again, there's your whole deviation and median room for numbers for error, and it's probably sitting somewhere in the vicinity of 1 to 2 millimeters from some of the papers and meta-analysis that have been conducted. So it is comparable, definitely, to static guides in terms of accuracy. But again, based on various clinical factors and patient factors and site factors, the numbers might be really variable. We have to sort of look at it not just at the average accuracy, but what about how much was it inaccurate in one case versus, well, how accurate did it actually get in another case? So it could be really, really accurate in one case and wildly inaccurate in another case. And on average, it will seem like it's not too bad. So that's where the challenge is in taking the numbers and the studies with a grain of salt. But of course, again, as we were sort of saying, if you've got a lot of experience, you can detect when something is way off track and something is not going right, and change your plan mid-course. So if you're an experienced user, the robotics probably will only enhance that. But if you're very inexperienced, then and you trust solely on that robotic system, then it's a bit of a problem.
Yeah, absolutely. So, on top of it, is there anything specific that robot can genuinely do better than the dentist itself?
Oh, it's a good question. I think in the right hands, it will probably be able to be more repeatable and more accurate, and it's every treatment will be a more predictable outcome, and it sort of can catch a mistake before it happens. I believe that will give the user, the operator, a moment to see what's going on and why it is that the robot is not allowing the operator to continue in that particular direction. Maybe it's something that might have been overlooked if one was placing that implant freehand. It gives you that second chance, that second eye that's looking over your shoulder to almost like a little nudge to say, hey, what's going on here? Why is that not continuing the way that I would have thought it's going to continue? Give you that opportunity to correct course before it's before some damage is done that's more hard to recover from. So I believe that's probably where it can do things better than what we can do if we're only relying on our brain and our mood on the day. So it
Yeah.
can sort of be a second point of reference, a second checker of our work.
Yeah, absolutely. I believe it can be much more effective if let's suppose, because I'll tell you a thing. Again, the other day I was speaking to Dr. Basque about it. It's one of the thing that dentistry is quietly breaking its dentists, because around 55% of dentists in this profession, they're stressed.
Yes.
And if you look at any sort of room, if there are around 100 dentists sitting, 17.6, around let's say 18 dentists, they're thinking about suicide. They're having suicidal thoughts. So that's the thing. This just does not even mess up with the patients and the treatment. Of course, it would definitely do. If let's suppose the dentist is stressed out, not in a very pleasant mood, something is going absolutely wrong in their life, it's going to directly impact their patient's treatment. And
Yeah.
on top of that, it's just not the patient treatment, it just creates an endless loop of cycle, which just affects the practice in a really negative way, which means,
Yes.
I mean, think about this. If the patient treatment is affected, they're not pleased with the treatment, right? They're going to be coming back to the practice, asking for refund, complaining, leaving negative reviews. On top of it, then the next patients who are potential patients who are going to be coming to the practice for the treatment, when they read those reviews, about the patient experience they have, they are going to be really hesitant to go to the practice. And this is definitely going to affect the practice in terms of their revenue, their growth, and the ability to compete in the
Yes.
dental
Yes.
profession in the market out there.
It's very true. It's if you don't get enough
Yeah,
sleep the night before a big surgery, then some mistakes can happen. Absolutely. So sometimes having that robotic friend in the background catching you out can mean, like you just said, the difference between a successful outcome, a happy patient, good referral base to someone that causes more headaches, more stress, costing you more money to fix your mistakes, and then the negative roll on effect, like you said, of they might have told their brother or sister to come and get treatment done, and now they're suddenly telling them to go somewhere else. So, one mistake can definitely cost a lot more than what it initially seems on the surface.
definitely. And on top of this, let me just put this evidence to you because I actually went and read about it. So, a 2026 network meta-analysis in clinical oral implants research looked at static, dynamic, and robotic guidance
Yes,
against freehand.
yes,
And they actually found that robotic systems were the most accurate of all of them on the angulation
yes.
and the apex position. So these machines are winning on the precision, right? So does that settle that?
That's a really good question. I actually read that paper. So there's quite a few conditions in that paper that sometimes do get a little bit overlooked. So they did find that the robotic systems, like you said, showed the most accuracy. However, the conditions were very specific and operator based that ended up with the robotics being the most accurate. Because in other studies, they found that robotics were had quite a larger degree of error. So it's a tricky one because in one study it shows certain things, and then in another study you'll find that there are some differing numbers and differing opinions as a result of the conditions that were taken into consideration. So it's I would say that it's still going to come down to very situational basis, very based on operator, based on patient, based on site, as to what potential treatment modality is going to yield the best outcome in that exact example. And sadly, it's going to be something that's really hard to show in these studies because a lot of them are done in vitro rather than on live patients. They're done on models where the clinical conditions are not necessarily taken as heavily into the equation, whether there's a lot of bleeding or whether the patient is moving around. There's so many little nuances that a lot of these studies will never have that opportunity to be able to truly test out, because at the end of the day, each individual implant in one patient is going to be different than the exact same location on the next patient, and even one site on one patient and the opposite site on the same patient are going to be two different situations as well. So really getting accurate data can be quite challenging in the end to know which is truly best. But of course, these numbers are not based on nothing. They are based on metrics that have been measured and been calculated. And I would say it's a very useful tool at the end of the day, rather than being the be all and end all and the only thing that an implant dentist should be aiming towards. I think it should be something that, as the technology continues to improve, that dentists who are very serious about implant placement and do place a lot should start to consider as an adjunct supportive measure for their treatments going forward.
Got it. That makes sense. And the dynamic navigation sits between the two, guiding you live on the screen while you drill. So you have not used it yet. So what exactly is it, that's holding you back? Honestly, like, is it the access? Is it the evidence, or is it the instinct?
At the moment, I would say it's the access. I did at one point almost have the opportunity to trial out the system, but it was a bit earlier on in my implant journey, and I believe there was not so much access at that time that was the issue, but instinct. I wasn't there yet mentally with my skill level to introduce another variable into the mix, as there would have been so many other things at the time of those surgeries I was thinking about, that making sure that the computer was working properly was the last of my priorities. So sadly, at the time, I didn't get to use it. Definitely now, if someone came and knocking and said, "Hey, give it a go," which I know the implant reps, if I approach them, would be more than happy to do so, that I would definitely give it a go. But it will become one of those things that the setup and the time that it can take to implement these new protocols can sometimes be a little bit prohibitive. Mostly for the full arch work
Yep.
that I do, but maybe for individual implants, it would be something that would make sense.
Hmm.
But then you go back to the literature and have a look at the numbers, and with dynamic guides versus static guides, there isn't really much difference. So that cost then really comes into play, where as cool of a toy as it might be, does it really justify the price tag associated with it, or should I stick to a static guide? Robotics is a different story, but with dynamic, I'm not sure the argument's quite there yet for the dynamic systems. I think it was a really good stepping stone for companies and engineers to get from static guided to fully robotic. I think dynamic maybe doesn't have a true home in the future.
Definitely. So that's correct, and it makes me ask you one question, because the question really is robotic implant surgery the future of accuracy, or is it more like a solution that's looking for a problem?
I think it will as technology, as you know, and in every field, is exponentially growing, and at rates that one could only dream of. And we look back and think there was no way that we would be where we are today with AI and all sorts of various forms of technology. So I don't want to be naive in saying that there isn't a future for robotics, because absolutely there will be. I can't fully dream about what it will be and how good it will be, and what conditions will facilitate that
Yeah.
to actually become the case. But by all means, I believe it will probably be something that, under the control and supervision of a surgeon or a dentist, will be a big part of clinical practice going forward. The question also does become, though, what do patients think about it? Because at the end of the day, we can try and convince our patients of things like we do every day, with the information we give our patients. But if they don't feel comfortable and they don't feel convinced that a robot's going to be involved in their treatment,
Yes.
despite us trying to tell them, look, it's more accurate, it's better, and so on. If they don't in their heart feel comfortable, then we might have this really expensive piece of equipment that only a small percentage of people feel comfortable enough to allow us to use it on them. So that's going to be a deciding factor, I think, for the trajectory, how patients in medical and dental feel about it. But
Hmm.
I think the accuracy will get there. I think the accuracy will get there.
Yeah, absolutely. I believe that is one of a beautiful point that you actually brought up, is because if the patients don't consent being treated by this sort of robotic machinery, then again, it's just going to be a huge amount of asset that would actually become their liability. So it's
Yeah,
it's really important for any sort of dental practice out there who's looking forward to buy this sort of machinery, is run some sort of survey or feedback through your patients. If they get a chance to get treated by this sort of robotic machinery, would they approve it? Is that something they would consent to or not? And
yeah.
I believe running this sort of survey is just going to help them a lot in making the right decision at the right time, isn't it?
Yeah, absolutely, absolutely. It's very easy to get carried away thinking about boys and their toys almost. Like, it would be so cool if we could do this, or cool if we could do that. But we always have to remember there is a human being attached at the other end to the treatments that we're doing, and what is it that they really want? Like, do they want the human touch? Do they accept that maybe there's a higher degree of inaccuracy, but maybe they trust in the ability of the human mind to be able to accomplish difficult things where a robot possibly might not be able to, despite on paper it's seeming that the robot will deliver the better outcome. So I agree, a survey that's a really cool idea, because it's a lot of money to put out front and only for it to sit in a room collecting dust if no one wants it to be operated. No one wants to be operated on it on themselves with.
Definitely. So that's been quite interesting about the robotics.
Yeah.
Now I definitely want to get to the heart of the podcast,
Sure.
and it's about the deskilling argument that just
Yeah.
keeps coming up, and I want your absolute, honest answer about this. So if the next generation of implant dentists trains only on guides and navigations, so who do you think will be able to operate when the technology cannot?
Yeah, it's a great question, and we need to sort of look back, I suppose, at dentistry and how far it's come so far. And there are lots of aspects of dentistry that myself, I don't practice, that we may have been taught at university, or even things that were pre my era of university, and at the moment they're replaced with completely different technology and completely different materials. For example, maybe a graduate that's coming out now, I was a little over 10 years ago, but if someone's coming out now, maybe they will have no idea what impression materials are. Maybe they only know digital scanners. And is there really a situation where impression material might work or a scanner might not? There's probably a few, but I'm sure that there's going to be a workaround as time goes on. So it will de-skill us in a limited sense, I believe. So for things like impression materials, another skill that I only learned how to do amalgam fillings on a plastic model. And when it came to placing one on a real patient, I hadn't ever done it, and so my supervisor stepped in and did it for me. And so I never actually placed an amalgam in the end on a real person. I went into private practice and never used it.
Yeah.
So again, a skill I never gained, but some would say it's not necessarily a skill lost. It's just something that is a past era. So when it comes to surgery, it's a difficult one, because I'm in the era where I have learned how to do it freehand, and I don't want to be the dinosaur in the room. So it's tough, because so much can possibly go wrong during surgery,
Yeah.
and it isn't so much that there's something better now. It's more that, are we learning how to navigate the difficult situations if we rely on these guides?
Yeah.
And if the answer is we're still learning how to deal with complications and manage the problems, and we're using the guides, then there's no harm in that. But if we forget learning how to deal with complications and difficult cases and identifying problems as they're occurring, and only relying on the guides, then absolutely we're losing a skill there that's really important. So if those skills, to repeat the same thing again in a different way, if as long as those skills are learnt first, then there isn't really a loss of skill. So that's got to be the foundational module, some would say, of any training program, is getting those dentists up to skill, and then throwing them into the world of technology and guides, and absolutely the limitations will drop away very quickly at that point.
Yeah, 100%. And there's also a version of this argument in the aviation
Okay.
as well. So pilots, they fly on
Yes.
autopilot, right? And the industry worries that they cannot hand
Yeah.
fly anymore. So the question really is dentistry walking into the same
Hmm.
problem that aviation is currently struggling with?
I suppose it will depend on whether it becomes an accessory, or whether it becomes something that's mandatory. If it's becomes an accessory to our hand skills, then it will be something that will most likely benefit us and assist us in continuing growth and improvement. But if the industry does somehow change in the future and says that you have to place everything with a guide, dynamic, static, robotic, then there is that risk that we will lose a skill. But it's tough. It will be based on more and more studies and collection of data to show, well, where are the complications occurring, and if the number of these complications seem to be growing and growing and growing, then maybe a moderator of the industry will need to step in and say, well, we can't keep doing things freehand because patients are suffering as a result. Let's switch gears and start to focus on ways that we can improve patient safety and predictability of treatment. So, unfortunately, yes, some people will then lose that skill, but at the end of the day, if the outcome is better for the patient, that's really what we're here to do.
Yeah, absolutely. And second, lastly, I would definitely want to cover about the implant surgery. Okay, what do you think the implant surgery would be there in the next 10 years?
I haven't given it as much thought as I probably should. That's when you're sort of stuck in the day to day, you don't really think too far ahead, probably 12 months ahead or 18 months ahead. I'd say that all I'm noticing from that department at the moment is that definitely more and more dentists are learning how to place implants and jumping in and placing implants. So there's a lot more capacity these days for patients to have implant treatment done, which is fantastic because not a lot of patients probably knew about implants 15 years ago or 20 years ago, and there was very few people that could help them. So now it's allowing the industry to move towards more growth, more development, more innovation. And the companies, of course, behind it, whilst they at the end of the day a company and trying to make profit and new innovations that can make them money and grow the industry as a whole, it will definitely open up doors for the continued technological development in the industry. So in 10 years, like, there is a very good chance that robotics will be a much larger part of our day-to-day work. The challenge will be knowing what it's going to be most helpful with, because I feel like as more and more implants are being placed, the increases in complications and failures and issues will also go up. Once upon a time, it was only specialists that placed implants, and they had to do lots and lots of training, and it was very selective few. So the outcomes, whilst it took longer for the industry to develop and improve, there weren't as high a level of issues and failures and complications along the way. And as the door opened to more and more general dentists, these complications are probably getting higher and higher. So it will be interesting to see whether robotics in the future can reduce that complication risk and reduce the failures that we're seeing, whether they'll maybe be able to even assist us with fixing some of the problems
Yeah.
that the implant industry is inadvertently causing as time is going to progress over the next 10 years. So it will be interesting to see.
Yeah, 100%. I would definitely agree you on that point. And if you look from my perspective, what I really believe in the next 10 years, what's really going to happen is this robotic AI. It's absolutely booming out there.
Yeah,
It's something, the way it's picking up its pace, it's absolutely absurd. I
yeah,
mean, we're living in 2026, a modern era that we never imagined how fast AI would be out there. I mean, just look at the data centers, these massive companies, OpenAI,
yeah,
Claude, how exactly they're becoming.
yeah,
They've become from a company that nobody knew to a billion and billion-dollar worth of companies
yeah,
in just a time span of, let's say, 2 years, 3 years.
yeah,
That's the pace the AI is definitely picking up, and it's the same case with robotics. What I really believe right now, a lot of implants surgeons out there, they definitely are doing a great work. Okay, but in the next 10 years, robotic would definitely not be in a place where it's absolutely going to replace the implantologist, right? It's definitely going to be out there assisting them. But yes, in the next 4 to 5 decades, there is a high probability where robotics will grow to such a threshold where there's a high stance of them replacing the implantologist.
yes,
So I believe it's really important that all these dentists out there, they definitely have to have some sort of backup plan as well,
yes,
right? These young dentists who are planning to become an implant surgeon, and they've got a next career of about 4 to 5 decades. So it's really important they have, first of all, they have their own backup plan,
yes,
um, whatever that is. Any
yes,
other profession where you think that the robotic and AI will not replace them, and yeah, I believe it's something that have a backup plan, and on top of that, just relax for now, because for the next 10 or 20 years, it's just going to assist you, not it's not going to replace you, isn't it?
Yeah, and try and get as much skill as you can. Find something that is not replaceable, like you said. That what there are things out there that only humans can do, and other humans are seeking that as well. Like having these types of conversations, these things will never be replaced really by AI, because people don't want to sit here and listen to two robots talking. No matter how interesting it is, the things that they're saying, we still want to have that human experience at the end of the day. And quite luckily, in the medical field, there's always going to be a degree of that, in my opinion, at least. I would think that if it was me being treated, despite a robot being more accurate than and maybe 50% of surgeons out there, I would probably still go out there and try and seek the surgeon who has a really proven track record
Yeah.
that could probably deliver a comparable outcome. And so, as that surgeon, whether dentist or medical, if I'm really, really skilled in my field, then I'll hope that the patients will come to me over going to a more junior dentist that's relying on the robotics because of the lack of skill, like we were talking about before. So, uh, definitely find something else to do. It would help, just in case. But also find a skill that is not replaceable would be the backup. If your heart is set on dentistry and you don't see yourself doing anything else, then find ways to level up in ways that a robot can never replace.
Right, that's absolutely perfect. Great. So we have definitely covered the majority proportion of the podcast. Now I want to get to the last part, which is something I always love to do with all of my guests I have on the podcast, which is rapid fire session. Okay,
Sure.
and you're supposed to just tell the very first word that comes in your mind, no explanation, nothing like that, and we're just gonna get started in three, two, one. Yeah.
Cool.
So guided or freehand,
Freehand.
static guide or dynamic navigation.
Static guide.
All right. Would you let a robot place an implant in your own mouth?
Not today.
Germany or Australia for implant training?
Germany.
Sweet. And the most overrated thing in implant dentistry right now?
Most overrated thing. Oh, I don't know actually. I don't, that ones I don't know. I don't know what would be the most overrated thing. What would you think it would be?
All right, no worries. I mean, probably their salary.
So, actually, yeah, I think there's definitely that misconception that it's salary is not sometimes not enough to deal with the stress that we go through.
There you go. There you go. What about the most underrated?
Most underrated. Uh, just general dentistry. General dentistry is very underrated. Everyone's trying to do the biggest and best and most complicated thing as soon as they step out of uni. Sometimes doing general dentistry first and communication with your patients and just being someone that takes it slow is definitely very underrated these days.
Hmm. Okay, and is there any sort of one implant myth that your patients believe that's just absolutely absurd?
Uh, I don't know how often they believe it, but I get asked a lot, will they beep in airport scanners? That's so, so
Uh-huh.
often they ask me, am I going to light up the airport scanner? So, where they get that from, I'm not sure.
Yeah, yeah, 100%. So, what about the best piece of kit you've ever bought?
Oh, my photogrammetry units. I've got a few, but they are probably, yeah, not by far, but very up there. Like an intraoral scanner is not only for implants and or just dental as well, but a photogrammetry specifically for implants has really made my digital workflow way more predictable and straightforward.
Mhm. Got it. And let's say a patient asks you for a teeth in a day. What's the first word that's going to come out of your mouth?
Sure, can be done. Yeah, sure.
All right. All right. Sweet.
Yeah,
And and nice. And one thing that you would just absolutely ban from the implant dentistry tomorrow.
something I would ban. Ooh. Probably very controversial, but I would probably ban zirconia implants.
All right, all right. And the best advice that someone has ever given you at the Goethe?
Best advice is take it slow and check everything you do twice. And there's always going to be more work that walks through the door. So it's okay to sometimes say no to a patient if you feel like what they're asking you for is not something that you can deliver. It's okay to say no to them and wait for the next person that comes through your door and hope that that is something that's more up your alley, because that one person that you say yes to that you probably shouldn't have, it will keep you up at night for more than it's worth.
Okay, got it. Well, that was that was good, and it was, I believe, more hard than the whole art itself, wasn't it?
Yes, yeah. No,
Yeah.
appreciate it.
So lastly, I just want to I want to cover a couple of things I definitely do have in my mind. And what is the hardest part of implant surgery that the patients just never see?
I would say it's the planning, the fit out of the surgery for with the equipment to be able to do the job to a really high standard. Yeah, training and fit out is probably the most overlooked thing in implant dentistry these days.
Hmm. Got it. And last one, this is something I just want to have yes or no.
So
So robots are placing implants now, right? Should you trust them at this point of time or not?
no.
Perfect. That's absolutely amazing. And honestly, Dr. Jonathan, it was great talking to you. Would you mind also telling individuals out there where exactly they can find you, and if they've got any sort of questions, where should they reach out to you?
Yeah, absolutely. I'm mostly just active on Instagram at the moment for social media. At John Michael is my Instagram handle. My clinic that I work in is Dental Boutique. So if someone is a patient and wants to come see me, they're welcome to come see me at any of the Sydney clinics, Dental Boutique Sydney clinics.
Perfect, Jonathan. Thank you. And that was exactly the conversation I hoped it would be, and honest, all about the technology and about its limits. So, if you want to find Dr. Jonathan, go out there, search his Instagram, drop him a follow, pass him great comments. And currently, he's practicing in Sydney in Dental Boutique. And if you're a dentist or a practice owner who wants to be on the podcast, share your story, just go to betweenpatients.online, apply over there, come on the show. And if you want to read more from me as well, my book, The $2 Dentist, again, it's going to be live at the Between Patients online. You can definitely check it out. I'm Moiskram. This is Between Patients.